Hi everyone, welcome again to another episode of our health assessment. At this point, we are to discuss the eye and vision assessment. So to start with, we start with, of course, our review of the anatomy and physiology of the eyes and the senses. So the visual system is consisted of different structures. This may involve the eye, accessory structures, and sensory neurons. For the eyes, it is consisted of eyeballs and your optic nerve. The accessory structures includes eyebrows, eyelids, conjunctiva, lacrimal apparatus, and extrinsic eye muscles. The following are the structures of your eyes. We do start from your eyebrows. So this prevents perspiration from entering the eyes and also help shade the eyes. The eyelids, which is found over the top bottom of the eye, and of course the lower eyelid. So it is consisted of five tissue layers that protect the eye from foreign objects. It also aids in lubrication by spreading the tears over the surface. So the lubricating glands associated with the eyelids are your meibomian glands and sebaceous glands. Ciliary glands are usually part of it, which lies between the hair follicles. Another structure is your eyelashes. Alright? These eyelashes are projecting from the free margin of the eyelids, and usually they do initiate the reflex blinking. And of course, the last one would be the conjunctiva. Okay, this covers the inner eyelid and of course the anterior part of the eye. The conjunctiva. There are two types of conjunctiva. These are your palpebral and the bulbar conjunctiva. The bulbar conjunctiva stops at the junction between the sclera and the cornea. It does not cover the whole cornea. Meanwhile, the palpebral conjunctiva covers the inner surface of both the upper and the lower eyelid. In the image that you can see, the palpebral conjunctiva are the ones usually covering the eyelid, and the bulbar conjunctiva are the ones covering the sclera. So in this image, you can see the difference between the bulbar conjunctiva and the palpebral conjunctiva. Both of these conjunctiva are clear. That's why when you observe or inspect onto the structures, you may still be seeing the natural color of the sclera and the lower eyelid or the inner portion of the eyelid. Another accessory structure is your lacrimal apparatus. It is composed of the lacrimal gland, lacrimal ducts, lacrimal canaliculi, and your nasolacrimal duct. This lacrimal apparatus helps in the production of your tears that usually is necessary for the lubrication of the eyes. Another structure is your extraocular muscles or the extrinsic eye muscles. These are six straps like muscles that usually maintain the shape of the eyeball and of course enable the eye to follow certain movement of objects. There are four rectus muscles that originate from the annular ring and two oblique muscles which moves the eye onto the vertical plane. Okay, this is another image of your uh, extraocular muscles. It shows the it shows your different muscles, the lateral rectus, the superior rectus, inferior oblique, the medial rectus, superior oblique. The eyeball is composed of three layers. The fibrous layer, which is making up the sclera and the cornea, the vascular layer, which is made up by a choroid ciliary body, and the iris, and the nervous layer, which is composed of the retina. The internal cavity of the whole eyeball is filled with fluid, which is called the humors. So this is the one that we're talking about, the fibrous layer, which is composed by the sclera, okay, the white portion, the cornea, the one that is covering or in the front or anterior portion of the eyes, the vascular layer, which makes your choroid, ciliary body, and of course your iris. The nervous layer, of course, which is wherein your retina can be observed. And take note that the retina is the most vascular layer of the eyes, which aids in our vision. This hollow area herein is composed of this, or what we call as the vitreous chamber, is composed or filled with lots of vitreous humor. This is just another image representation of the different layers of the eyeball. So the fibrous layer, the nervous layer as well. This one is a close image of your pupil and the lens. The brown-like structure over here is your pupils, and the middle layer is your lens, no? Which aids in the refraction of the light towards the eye. There are two parts of the pupils. Your sphincter pupillae, which is the inner portion, and the dilator pupillae, which is the outer portion. Of course, the sphincter pupillae aids in the constriction of the pupils when light is being refracted to it. And of course, your dilator pupillae aids in dilation when there is minimal source of light. This is an image representation of the retina. No? This is actually the left eye because this is the medial side of the eye and the lateral side of the eye. On to the retina, we can observe the different blood vessels or the retinal vessels. Your macula with its fovea centralis, and of course, the optic disc. There are different refractive errors that we can observe from patients. When we do say refractive errors, there could be problems with the refraction or the reception of the light towards the retina of the eyes. Remember that the retina is where the light is being projected on and later on helps us in vision and identifying what we are seeing. So with the normal eye, we can see that the lines here represents the light that our lens, the eyeball is receiving. Okay, as the light passes through the lens, it goes and refracts or reflects to the retina. Okay, with the normal eye, the light that is being received by the eye is landing on our retina correctly. And there are different refraction errors, actually three: the nearsightedness, farsightedness, and astigmatism. With nearsightedness, the light usually focuses in front of the retina or before the retina. So, meaning the light does not reach the retina itself. That's why it is nearsighted. Then for the farsightedness, meaning there is an over reflection of the light. So it surpasses or goes beyond over the retina, as you can see in the image. For astigmatism, it is actually a common and generally treatable problem of the eye, which usually caused by curvature of the lens, which causes blurring of vision or at times near vision. Astigmatism occurs when either of the front surface of the eye or the cornea, or at times the lens inside the eyes, has mismatched curves. It can also happen when the cornea or the lens has an irregular curvature. So in this another representation, you can see the difference between the four uh, visions. For the normal vision, the light usually ends or lands over the retina. For the nearsightedness, it lands before the retina. For farsightedness, the light lands after or goes beyond the retina. And of course, for astigmatism, there is error in the reflection of the light, which is usually distorted, causing now blurring of vision. So farsightedness is a condition affecting a person's vision, and people with this one typically have easier time seeing objects that are far away. They do have a difficult time focusing their eyes on things that are close, like words in a book. Meanwhile, nearsightedness, or what we call as myopia, is a common vision condition in which you can see objects that is usually near to you clearly, but objects far away are usually blurry. It occurs when the shape of the eyes causes light rays to bend incorrectly, focusing the image in front of your retina instead of the retina itself. And of course, astigmatism, as we have mentioned earlier, is a problem caused by the distortion of the light that is being reflected on. So the following are common visual problems, no, or problems with the structures of the eye. Okay, first would be your conjunctivitis. Conjunctivitis is also known as your red eye or at times pink eye because of its discoloration. It may be caused by viral infection, bacterial infection, or allergic reaction. Next one is your dacrocytosis. Okay, this is actually an infection of the lacrimal ducts where the tears usually comes out. So as you can see in the image, there is redness and pus filled here over the lacrimal ducts. The other one that you can see is your sty, or what we know is as your hordeolum. Or hordeolum is an infection of the meibomian gland, which is the one that is lubricating the eyelashes. This one is your iritis, meaning there is an inflammation of the iris. Okay, this may be due to trauma. And lastly is your periorbital hematoma. Hematoma is actually a collection of blood underneath the skin, which may be caused by trauma. So other conditions may include cataract. Cataract is a problem with the lens. Usually it comes senile, meaning when you go older, you develop uh, problems with your lens that causes blurring of vision. The second one is coloboma, which is an eye abnormality that occur before birth. So large retinal colobomas are those affecting the optic nerve, which can cause low vision, which means vision loss that cannot be completely corrected with glasses or contact lenses. And the last one is your arcus senilis, which is a presence of a gray or white arc, as you can see in the image, over the outer part of the cornea. This is the cornea, the covering over your pupils and your iris. So there is whitish discoloration onto the outer portion. So the clear dome-like covering, which is the cornea, is usually affected. So arcoceneris is common in older adults, and it is caused by deposits of fat or lipids in the outer part of the cornea. So in patients such as this, cholesterol and triglycerides are usually the ones that causing its effect. Other conditions or observations that you may see is your meiosis. When we do say meiosis, it's actually a constriction of the pupils. The pupils is the dark or the black area that you can see at the middle portion of the eyes. Okay, this is an example of a constricted pupils, while the other one is your dilation of the pupils or what we call as the mydriasis. Okay, a condition that is appearing to be to have presence of unequal pupillary dilation, meaning one is dilated and the other one is constricted, is what we call as anisocoria or unequal pupillary dilation. These two are actual conditions on your eyelids. It can happen in both the lower and the upper eyelid. Okay? The first image that you can see onto your left is your ectropion. What do we mean by ectropion? When we do say ectropion, it's a common condition which the eyelid turns outward, as you can see in the image. This leaves the inner eyelid surface exposed and prone, of course, to irritation. Ectropion is more common in older adults and it is generally affecting the lower eyelid. In several ectropion, the entire length of the eyelid is turned out that cause, at times, this ectropion may be caused by Bell's palsy, at times lump present on the eyelid, a tumor, cyst, injury, sometimes burn, contact dermatitis, or maybe related to previous surgery. While your ectropion, the image on your right side, is a condition in which the eyelid usually, the lower ones, is turned inward. That's why it is called as entropion. Therefore, the lashes rubs against the eyeballs, causing pain and discomfort. So this is a condition in which the eyelid turns inward. Again, can be caused by muscle weakness, scars, eye infection, and later on can lead to infection. This is another condition of the eye, specifically to the eyelids, wherein the eyelids is usually um, covering at times a part or half of the eyes. Okay, this is what we call as ptosis. So ptosis is generally a drooping of eyelids, especially your upper eyelid. No, so the eyelid may droop just a little or so much that it can cover the pupil and later on may do affect the vision. Ptosis can limit or even completely block normal vision. So it can happen in both children and in adults. For adults, they usually do get ptosis coming from due to the condition of the levator muscles that usually stretches and separates from the eyelid. It can be caused by aging or at times eye injury. Ptosis can also be seen in some patients or in patients who are having Bell's palsy. So how do we determine the presence of ptosis? So your MRD, or what we call as your margin reflex distance, okay, is the distance between the upper eyelid and the light reflex, which is found over your cornea. This is the reflection of light over the cornea. Okay, A ptosis can be considered mild if the drop of the eyelid is about 2 millimeters or 1 to 2 millimeters. For moderate ptosis, it's about 3 millimeters droop, and severe ptosis if it actually covers half of the eyes, no, or about 4 millimeters of droop, or even more. So now let's move on to the assessment of the eye structures. We're done in looking back onto the structures, reviewing some of the possible problems or findings that we may see from your patient. Before we start the procedure, of course, you have to identify and gather all of your equipment. So these are gathered all at once prior to the assessment so that you'll be able to save your time, of course, and do the assessment in an organized and systematic way. So equipment should you use are millimeter ruler, pen light, Snellen chart, or what we also call as E-chart. At times, you can use children's chart for children. An eye cover, of course, gloves to be used for inspection, cotton tipped applicator or cotton balls, ophthalmoscope, or if none, you can omit this one, use only pen light, your Amsler grid, a pinhole, and newsprint or a book for reading. Second, prior to the performance of the procedure, of course, always introduce yourself. Introduce yourself and verify the client's identity using the agency protocol. You would want usually to ask the patient of their name rather than mentioning what their name is. Third, explain to the client what you are going to do, why is it necessary, and how he or she can participate. Discuss how the results will be used in planning further care or even treatments. It is necessary before you start the actual procedure to perform hand hygiene. Application of gloves could be necessary if in case there would be presence of infection and exudates from the eye structures of your patient. Of course, make sure to observe other appropriate infection prevention and control procedures. Always provide clients privacy. You can do it by either doing the assessment in a private room, closing the door, or the curtain. At times, in public spaces of the clinics or hospital, you can have privacy curtains. You should always also ask of clients' history that could be related to the development of eye or vision problems. So you start by asking family history of diabetes, since diabetes may lead to the complication of diabetic retinopathy, as well as hypertension, blood dyscrasias, which may lead to the rupture of the blood vessels of the retina, causing now blurring of vision, and the worst is loss of vision. You ask also any previous eye diseases, any injury that may lead to the development of eye problems caused by injury or surgery. So ask also when was the client's last visit to a health provider, especially to those of an ophthalmologist. Ask for any current use of medications. There are current medications that causes constriction of the pupils and or dilation. Use of contact lenses or eyeglasses for either correction or aesthetic purposes. And of course, you may also ask the hygienic practices of these patients who are using corrective lenses. Ask current symptoms of eye problems such as changes in the visual acuity, blurring of vision, tearing, spots, photophobia, itching, or pain. So I'll be presenting some of the symptoms or complaints that your patient may have. First is diplopia. Diplopia is doubling of vision. As you can see in the image, there are doubling of the letters of the word diplopia. Another symptom that your patient may uh, complain of is your blurring of vision, presence of spots or a black or darkened area or a blocked area over an image or to the area he or she is looking at. Presence of halo as well should be asked, or maybe your patient could be complaining of. Halo vision are usually the bright circles that you can see around or surrounding the light source, such as on the cars or in the light bulbs. Or at times, glare is when the light usually that enters the eye and interferes the vision. So another complaint that your patient may be having is your tunnel vision. Tunnel vision because it seems like you are entering or passing through a tunnel. Remember that when we pass through a tunnel, all the other sides of the area is dark or black because of the absence of light. And of course, the only one or the only area that you can see is at the center. That's why it is called as your tunnel vision. It may be seen in some patients who are having glaucoma, diabetic retinopathy, or at times those patients who are having stroke. Another one is your floater. Okay, these are collagen, usually coming from the vitreous humor. They are drugged, clumped, little shreds of collagen from the vitreous. This is seen in patients who had sustained an eye injury, who's having a diabetic retinopathy, eye tumor, detached retina, at times presence of bleeding in the vitreous and or infection. So looking now, you know already the possible complaints of the patient. You start by inspecting the patient's eye structure using your eyes, of course. If you have to palpate, you may do so by wearing your gloves. So inspect the eyebrows of the patient, the eyelashes, and of course, the both lower and upper eyelids. So inspect for its hair distribution, alignment, skin quality, and movement. So you may ask your patient to move the eyebrows, squint their eyes, or close the eyes tightly. Normal findings could be hair that is evenly distributed, the skin, of course, intact, eyebrows are symmetrically aligned, and equally moving with the other side. So abnormal findings are loss of hair of the eyelids, the eyelashes, presence of scaling because of the dryness, as well as flakiness of the skin. And of course, another is an unequal alignment and movement of the eyebrows. Next, inspect the eyelashes for evenness of distribution and direct curl. So the quality of the distribution should be observed and it should be curled outward because if the eyelashes are curling towards the eye or inside, it may cause an irritation. Next, inspect the eyelids for surface characteristics, position in relation to cornea, ability to blink, and frequency of blinking. Inspect also the lower eyelids while the client's eye is closed. So normal findings are the following. Skin should be intact, no presence of drainage, nor any discoloration. The lids should closely be symmetrical. Approximately, the blinking of your patient is about 15 to 20 involuntary blinks per minute. When the lids are open, no sclera above the cornea, and upper and lower borders of the cornea are slightly covered. Abnormal findings could be redness, swelling, flaking, crusting, presence of plaques, discharges, nodules, and lesions. So looking onto the lids of the patient, it may be looking asymmetrical. Then for the movement, it should be rapid, uh, monocular, absent, and infrequent blinking. Look also over the eyelids for any presence of ptosis, as we have seen earlier, an ectropion or entropion. The rim of the sclera should be visible and between the lid and the iris. Ninth is that we inspect the bulbar conjunctiva. Okay, you can also include the palpebral conjunctiva. Check for the color, texture, and the presence of any lesion. So the normal findings that we may get that the bulbar conjunctiva is transparent, meaning you can see clearly the sclera of the patient. Capillary sometimes evident, but not usual, or but not always. The sclera appears white, if in case darker or yellowish, and with small brown macules in dark-skinned clients. Normal findings are your jaundice, sclera, excessively pale sclera, reddened area, and or at times presence of any lesions or nodules. So these two are the comparison between a normal and an icteric or with the presence of jaundice sclera. The one that you can see on your left side is a clear uh, palpebral and clear and pinkish palpebral conjunctiva and clear and white bulbar conjunctiva. Okay, again, that the palpebral conjunctiva is the one that can be seen uh, over the lower eyelid or over the eyelids, both upper and lower. And of course, the the bulbar is the ones covering the sclera. That's why it still looks like white, but it is clear. Onto the right side of the screen, you can see the yellowish discoloration of the sclera, which is supposedly white. This may be caused by problems in the biliary tract, problems with the hepatic tract of the patient, or at times the liver itself. So yellowish discoloration is termed as jaundice. After that, you remove the gloves and of course perform hand hygiene after removal of the gloves. At this point, you will not be touching the any eye structure of the patient anyway. Now, let's now inspect the cornea for clarity and texture. Remember that the cornea is the clear covering of the eyes, specifically the iris and the pupil. So ask the client to look straight ahead, hold the pen light at an oblique angle to the eye, and move the light slowly across the corneal surface. So the normal finding should be the cornea is a transparent, shiny, there could be reflection, and smooth. So details of the iris are also visible. An abnormal finding is an opaque surface is not smooth of the cornea. In older people, a thin grayish-white ring around the margin called the arcus senilis may be evident. So arcus senilis is usually seen in those patients who are older and not in less than 40 years old. So the cornea should be clear with the presence of reflection. Okay, this is clear. However, there is presence of arcus senilis, the whitish discoloration of the cornea, especially at the uh, outer ring. You should also check or assess for presence of red light reflex. Remember, red light reflex is a normal finding. So sit about half a meter or 50 centimeters away. Hold the ophthalmoscope in front of the patient, or if you don't have, you may use your pen light close to the eyes. Encourage the patient to look at the light source the direct direct the light at the child's eye individually and together. you use or you should see an equal and bright red reflex from each pupil. The following image is an example of a red light reflex. It is like when you do capture a picture you with a flash or with a camera with a flash. Okay, there could be presence of a red light over the eyes because the these are normal because these are actual reflection of the light hitting the retina and it bounces back. That's why it is colored red. Okay, so the image on the upper portion is the one that you should expect. It should not be white in color, rather red to orange light reflex. So normal red reflex and the corneal reflex are pres there could be presence of color and brightness of the red reflex, and the location of the small white corneal reflex is identical in each eye. So if it is absent, no, it could be it could be an indication of a cataract or a cancer, which is retinoblastoma. So a red reflex is abnormal and usually appearing to be wrong color, such as in the image, usually seen both again in cataract or retinoblastoma. Uh, for the squint eyes, no, a squint is a common indicator of retinoblastoma as well. Always do a red reflex test on a child presenting with a squint in order to rule out serious eye disease, which is an abnormal red reflex, which squint requires an urgent referral. Now you should reflect uh, the light, or you may be using a pen light over the corneal surface of the patient. This is actually called as Hirschberg test. You can do this by holding a light uh, in front of the patient, usually at the center. Then the normal finding is when the light falls symmetrically at 6 o'clock on both pupils. Okay, for example. Okay, what we mean is that it should be symmetrical on both areas or should be found in the same place. An abnormal finding is when light falls off center on one eye. So in this case, we can see that there's presence of reflection of light over the shiny cornea. So Hirschberg's test can actually help us detect a presence of uh, eye problems. Okay, usually the ones that resting eye. Okay, so an esotropia is an actual problem of the eyes, wherein it usually turning outside. So the reflection of the light over the cornea would be a basis for inward turning, outward turning, downward or upward. Okay. If you can see onto the image, this is a normal, the ones in your right, is a normal cornea or the normal placement of the eye, wherein the white dot as representing the reflection of light is found at the middle or the center. While onto the right side, you can see that the light is falling over the 3 o'clock place, meaning that the eye is moving inward, showing now the reflection of the light onto the lateral side. Another is your exotropia, meaning that the eye is turning outward or towards the lateral portion. Again, on your right side, you can see the normal reflection of light over the center of the cornea. At this point, it is still at the center. However, you know that the eye is moving outward since the dot or the reflection of the light can be seen at 9 o'clock. So hypertropia is what we call when the eye is turning outward. Okay, we can see that the reflection of the light is found at the 6 o'clock area and turning downward or hypotropia if it is found at the 12 o'clock uh, site. You can observe, looking on all of the images, that the reflection of the light will always be at the middle or at the center. It is only the eye that is usually turning either inward, outward, upward, or downward. A corneal reflex, or what we call as blink reflex, can also be tested using a cotton wisp or a cotton tipped applicator. We'll just slightly wisp the cotton over the lateral portion of the or the outer canthus of the eyes, touching the cornea, which should cause blinking. At this point, you have your client fixate on a near-far object to test for presence of squinting or resting of the eyes. So, fixate on a near or far cover one eye, and observe for movement of an uncovered eye. So, the normal finding is that the covered eye, either left or right side, should not move, meaning it should stay in place. An abnormal finding is if there's presence of misalignment and when the dominant eye is covered. The uncovered eye will usually move to focus on a specific object. So in this example, uh, with the letter A, alignment appears to be normal when you are not covering yet the eyes of the patient. So the next thing to do is cover the right eye because you would want to test the right eye. Remember, the one that you are covering or the eye that you are covering is the actual eye that you are assessing. So when you do cover the specific eye and remove the cover later on, the normal finding should be still it is in place. However, when you cover one eye, then it drifts onto the side or either upward, downward, left, or right, which means it's an abnormal finding. So for the visual acuity, we do assess both the distance vision or far vision and your near vision. So at this point, we do start with your far vision. So assess the distance vision by asking the client to wear corrective lenses if there is, unless they are used only for reading. They may remove it. Of course, the normal finding should be a 20/20 visual acuity. An abnormal denominator of 40 or more on the Snellen's chart, of course, is an indication of an abnormal finding. So this point, you ask the client to stand or at times sit 6 meters or 20 feet away from the Snellen chart if we are using the standard Snellen chart size. Okay, there are different sizes of the Snellen chart. So take note if you do use a specific size, make sure that the patient is standing or sitting uh, afar with the right distance from the chart. So at this point, you cover the eye not being tested and identify the letters or characters on the chart. We do usually start the assessment of the right eye, meaning you should cover the other eye, which is the left eye. Take 3 readings. So start with the right eye, do the left eye, and with both eyes. Record the reading of each eye with both eyes. Example, the smallest line from which the person is able to read one half or one more of letters. At times, visual acuity can be corrected, maybe because it is caused by an error of refraction. Okay? And we can check if it is an error of refraction if we do a pinhole testing or cover the eyes with a pinhole. This is what you call as a pinhole effect. The effect is that the blurry eye could have a clearer vision if you do use a pinhole cover or a cover with a pinhole, okay, which may indicate an error of refraction. So vision does not improve if with problems with the retina. Okay, if it is if it is only a problem with the refraction, a pinhole can correct it. But if it is caused by a retinal problem or any other, a pinhole does not correct the vision, or there would be no vision improvement. And thus, pinhole testing should be performed. So at this point, if the client is unable to see even at the top line of the 20/20 vision of the Snellen chart, perform selected vision tests. So you ask the patient to move 5 feet closer to the chart. So the numerator now will be written 15 over 200. Why 15? 15 the numerator because it is the distance of the patient from your chart. Remember with the vision of, for example, 20 over 200, the numerator is always the distance of the patient from the chart or from the object he or she is reading. The denominator is the distance of a normal individual or an individual with a normal vision can read the distance where you at 20 feet can read. So if the patient still moved at 15 meters away from the chart, you can ask the patient to move again closer to the chart. So move again by 5, making it 10. If still cannot, move again up to 5 feet distance from the chart. And what if the patient cannot still see from that distance, 5 feet? He or she cannot still read the largest letter at the topmost portion of the chart. We perform counting fingers. So in 4 feet distance, cover one eye with one hand or using an eye cover. You ask the patient to count how many fingers you are presenting. So perform with and without correction if you have to, or if the patient is having uh, eyeglass. Pinhole should not be used for close vision. If again the patient cannot see this one, you can ask the patient to come closer by 1 feet, up to the distance of 1 feet from the hands or from the assessor. If again counting fingers cannot be identified by the patient, you just move the hands and ask the patient if he or she can see any presence of movement. And if again the patient cannot see the hand movement, check now for light perception, meaning we would want to see if the patient is recognizing or seeing light. No? So ask patient to verbalize if he or she perceives light as you shine it. You may use your pen light. So if then the patient responds is yes, you ask the patient uh, to which quadrant or to which area he or she can see or locate the light. At this point, you'll have to record the patient's chart, light perception with projection. For the hand movement, you document it as uh, perception of hand movements. Or if counting fingers, you document it as uh, counting fingers. However, even you do the light perception, what if the patient cannot still recognize where the light is coming from? So you only ask the patient for light perception. Because earlier you would want the patient to identify where he or she can locate the light or the area of the light. If he or she cannot locate it, you just ask the patient if he or she can see any light at the same distance. So if in case the patient see this one, record it as light perception. So this is just an example of how you document your findings. OD stands for oculodexter, which represents the right eye, and OS, which stands for oculosinister, which is representing the left eye. So 20 over 200, for example, at a distance, 20. So this is again the sequence as a summary for the Snellen's visual acuity. So the distance of the patient from the chart should be 20 feet. If he or she can read the distance up to 20, you can record it as 20 over 20 vision. If not, move the patient 5 feet, another 5, another 5. Again, for visual acuity testing using the Snellen's chart, you place the chart 20 feet away or 6 meters away from the patient. Okay, so one eye should be covered with an occluder on an eye cover. So again, the right eye should be the ones to be tested first. So cover the left eye, then do the other side. Okay. Then the third time you do assess using both eyes. So the patient is asked to read the letters and vision is recorded. Each letter represents a certain vision. The largest letter represents 20 over 200 and the normal vision is 20 over 20, meaning the distance of the chart or the distance of the patient from the chart is 20 feet or 6 meters. Visual acuity can be also assessed using via the near vision. So if a client can read, no, you ask the ability to read. So assess the near vision by providing adequate lighting and asking the client to read from a magazine, a newspaper, or a book held at a distance of 14 inches from the eyes. So if the client normally wears corrective lenses, the glasses or lenses should be worn during the test. So how do we do this? Do this is that you may ask the patient to sit, then hold a newsprint, a newspaper, a book, or something, give him something to read, and hold it 14 inches away from the eyes or from where the patient can see it correctly or clearly. Then ask the patient to read. Normal finding is, of course, that the patient is able to read the newsprint without difficulty. Difficulty in reading newsprint, unless due to aging process, may be documented as an abnormal finding or poor vision. This is how you do the near vision assessment, okay? Sitting with 14 inches away from the eyes. Testing for the visual field. So we would want to see the peripheral peripheral vision of the patient. So assess peripheral fields to determine function of the retina and neuronal visual pathways to the brain, and of course the second or the optic cranial nerve. So normally when looking straight ahead, client can see objects at the peripheral or what we call as the peripheral vision. An abnormal finding is that visual field is, could be smaller than the normal. Possible glaucoma is a cause, and one half vision in one or both eyes could be assessed, such as seen in patients with possible nerve damage. At times in patients who had stroke. This image show us how you do perform the assessment for the peripheral vision. Okay, you usually ask the patient to cover one eye, then the other eye. Again, we do start by assessing the right eyes. So as the assessor or the nurse, you cover your own eyes for you to be able to verify if the client is seeing it correctly, or you can measure uh, the angle of the peripheral vision. So in testing for the visual field, take note of the normal degree angles of the peripheral vision. For the temporal field, meaning if you are assessing the right eye, the temporal area is onto the lateral portion, the one that is near the temporal bone. Okay? So the temporal field is normally 90 degrees visual field. The upper visual field is about 50-degree angle. For the downward, it is 70-degree. In the nasal field, if you are assessing the right eye, it is the at the midline or near the nose at 60-degree angle. Of course, do not forget to inspect the pupils. So, for its color, shape, and symmetry. Normally, the pupils is black in color, and check the size as well. Normally, it is 3 to 7 millimeter in diameter. So it should be round, smooth, with smooth border, and iris could also be seen flat and round. An abnormal finding is cloudiness, constricted or dilated, anicosuria or an abnormally different left and right result. Bulging of the iris towards the cornea is also could be possibly an abnormal result. Assess for each pupil direct and consensual reaction to light to determine the function of the third oculomotor and the fourth trochlear cranial nerve. Illuminate the pupil, constricts, and usually it is called as the direct response. The non-illuminated pupil you should also do constricts and called as your consensual response. Remember that when we do say direct response, it is the response of the specific pupil that is receiving the light source. Okay, that's why it is direct because of the direct uh, light over it. Consensual is that the normal finding is that both pupils should constrict and dilate at the same time, even if the ones receiving the direct light is only one of one of the eye, one of the pupils only. The response should be brisk, no, and not sluggish. So an abnormal finding is a sluggish response or at times absent response. It is fixedly constricted or fixedly dilated. An abnormal finding is anicosuria as well, unequal pupillary constriction and dilation. So this is an example how you assess the pupil. You may do dim the light so that you may see the dilation of the pupils, and you direct the light to both the left and the right eye, coming from the lateral portion or the temporal area. In this image, you can see the direct pupillary reaction, which is the reaction of the eye being illuminated, and the consensual reaction, meaning the reaction of the eye that is not being illuminated. So assess also the pupils for its accommodation. So pupils constrict when looking at near object and pupils dilate when looking at far object. So pupils converge when near object is moved towards the nose, and an abnormal finding is one or both pupils fail to constrict, dilate, or even converge. Usually we describe the pupils' reaction as perla, or pupils are equally round, reactive to light, and accommodation. So this is how you do an accommodation. You ask the patient to look at the tip of a pen or at times your finger or any object that you may be holding. Ask the patient to look at the far area or a far object and then observe for the size of the pupils and then ask the patient to shift the eyes over the pen or the fingers or anything that you're holding as for the near vision. So by the transition, you can observe that the pupils will converge, meaning it will focus over that object you are pointing at or holding, and also check for the constriction of the pupils. Normal finding is there is presence of convergence and constriction of the pupils. For the extraocular muscles or the EOMs, assess the six ocular movements to determine alignment of the eyes and coordination. Normally, both eyes are coordinated and moves in unison with parallel alignment. Eye movements not coordinated or parallel are abnormal, and one or both eyes fail to follow a pen light in specific direction is strabismus. Nystagmus can also be assessed, which is a rapid involuntary rhythmic eye movement. So to do this, stand directly in front of the client and hold the pen light at a comfortable distance, such as 1 feet or 30 centimeters, in front of the eyes of the client. Ask the client to hold the head in a fixed position, facing you, and to follow the movement of the pen light with eyes only. Move the pen light in a slow, orderly manner through 6 cardinal fields of gaze, that is from the center of the eye along the lines of the arrows, in, back to the center. Stop the movement of the pen light periodically so that nystagmus can be detected. So to test for presence of any other problems, you may use an Amsler grid, okay, and perform an Amsler grid testing. Ask the patient to hold the Amsler grid closely enough where he or she can see the tool clearly, usually same as distance with the assessment of the near vision, about 14 inches. Instruct to look at the dot at the center of the tool and ask for any presence of distorted lines and or covered areas or blocked areas. In case of presence, ask where he or she can see it. This is an example of an Amsler grid. This is a normal Amsler grid. You ask the patient to look at the dot at the middle. So while he or she is observing, normal findings like this one, the patient can see it as is. At times, patient may see presence of distortion or broken lines, or at times presence of block. In this case, the black area, it could be colored white or colored black. No, it is called as your scotoma. This is also another uh, representation of scotoma, but it's just color white. The grid lines should be straight. If the patient sees it as distorted or misalignment of the lines, there may be presence of metamorphopsia. So again, the right image that you can see is the normal finding, and presence of metamorphopsia is when there is distortion of the lines, and scotoma if there are blocked areas or presence of blind spot. After checking the Amsler grid test or doing the Amsler grid test, you can now finally document your findings in the client record using printed or electronic forms and checklists supplemented by your narrative notes when appropriate. So thank you for listening. You may watch the video presentation on how to perform the eyes and vision assessment.